Glad you could make it. What's up? What's up? I'm going to go ahead and get our slides ready to go while we are waiting for our co-hostess with the mostest. And in the meantime, let's go ahead and project those slides. All right, so welcome in, everybody. Hey, there's Erin. Let's get her promoted to panelist. And yay. Hello, Janet. How are you? We have Trudy, we have Charla, Nuria, Matt. What's up, Matt? We have Alicia and Lindsay and Janet. Okay, hey, Erin, you're welcome in. I think you're still on mute.
Hello, good afternoon, evening. Yeah.
Yeah.
I still have sunlight. Yeah.
So I'm gonna go ahead and share our slides and I'll let you kick it off.
Awesome. So, let me introduce myself real quick because I know a lot of you may know Jen, but maybe don't know me as well. My name is Erin Lee. I'm a nurse practitioner. I'm a family nurse practitioner by training. And I have been working in the cardiology space for the last 6.5 years in outpatient cardiology, but I worked in primary care for 8 years before that. And I love teaching and mentoring, which is exactly why we are here. And Jen and I have been working together the last couple, almost 6-ish months now, Coming up on 6 months, I think. Really trying to help support, clinicians, APPs, also nurses, to help strengthen your cardiology knowledge and get your confidence up and help you provide amazing care to our patients. So we're really excited to have you guys here tonight. And this is meant to be a very interactive and fun, presentation. We want you guys to talk and tell us what you're thinking. So thank you for being here.
Cool. And if you don't know me, if you just stumbled across me as well, my name is Jen Carlquist, PA, 16 years working cardiology and ER med. And like Erin said, we've been working together now, fostering and nurturing the new providers that are, kind of swimming upstream a little bit and needing some help. So in that project, we've really learned and honed in on what's important to newer providers and honestly providers of all levels. So we're going to talk about some of that tonight. And so what I wanted to just touch on first is that the reality check of chest pain, it doesn't matter where you work, it's going to find you. And speaking of that, we'd love to know, what setting do you work in? Are you an outpatient? Are you an inpatient? Are you primary? Like, where are you coming from? Because we'd love to kind of customize this a little bit more to you. So type in the chat, where are you coming from? And here's the reality is that I remember I was working in primary care for the first maybe month or two of my career. And I literally thought, oh, I'll be safe here, right? I'll be safe. No patients can come in that are going to be super sick while I learn my craft. But no, unfortunately, people still find you no matter where you are with all this really sick complaints, unfortunately. So yeah, it looks like we have primary. Yes, awesome. Erin used to do primary. Cardio APN, nice. Inpatient hospitalist, okay. Primary care, inpatient cardiac floor, awesome. And cardiology MP, nurse educator, awesome. So yeah, this is going to be perfect for all of you. So let's keep going with the chest pain lecture. So when you think about chest pain, or at least I think about chest pain, I kind of think about the fact that I need to pick up the serious differentials that can't leave the office if I'm an outpatient, right? And if I'm in the ER, I'm thinking, what can I not miss before they leave? So the top of the list would be ACS, of course. We're always thinking about that. But while we're on that topic, I want to quickly speak to that there's been some new changes that have happened. And the landscape of chest pain is not what we remember or what we were taught. And what I mean by that is there was some new guidelines that were put out in Journal of American College of Cardiology in November 15th, 2022. I remember the day because I have so much PTSD around this because not anybody read that article and it's full of new STEMI equivalents. So the paradigm shift that's happening in the chest pain land is that we need to know the new STEMI equivalents in addition to knowing STEMI, which was already hard enough. So they've piled more on our plate. It's made it more complicated. And then factor in the people that are coming in super atypical. Maybe we don't use that term anymore, but patients that are not coming in with the usual complaints. And then it's become even more difficult. So we really just need to have our radar up. We need to have our differentials wide. And we really need to listen to what the patients are saying. I actually had a case of a patient who recently had something that I know you've all heard, right? Sharp chest pain. It's been going on for a year, 65, some comorbidities. And she actually, it sounded so benign. Her EKG was benign. She ended up eating a cabbage. So even sharp chest pain doesn't get you off the hook anymore. Even giving a GI cocktail and the pain going away doesn't get you off the hook anymore. So the landscape's changing. So that's why we kind of wanted to get you guys on here tonight to give you the heads up so that you can be ahead of this game, right? And really make sure you know the findings. So the other thing would be CHF, with which Erin is an absolute masteress of, I think. She does a lot of our CHF talks in our program. And then, of course, thinking about things that are non-cardiac, right? So AAA, a dissection, right? That would be something that a patient could say. There are a couple of buzz phrases we'll talk about, some red flags. And those things would be like, stop, drop, and roll. You're going to the hospital, right? If you have something severe going on. Now, of course, PE would also make that list, pulmonary embolus. And believe it or not, there's a lot of signs on the EKG for PE. And the biggest sign, and this is often a board question, is tachycardia. And so anytime, this is pro tip number one of the evening, anytime you have somebody who has unexplained tachycardia and dyspnea, please always think about PE. Okay. And we talk a lot bit more about the findings later in our program, but getting back to other things, pneumonia, COVID, what else can you think of? Type in the chat that should go on this list for chest pain, because I haven't listed all of them. There's a bunch more out there, but tell me what you think. What else should go on this list? And while you're typing that in, we're going to just cruise on over to the next slide. So we've got pneumo, absolutely. Jennifer, you're in, oh yeah, so you're right up. Erin is probably have hearts over your head. Yep. Yeah, so Erin has some awesome background to talk about later probably. But anyway, let's talk about the big five. So the big five are the ones that you really can't miss. And there's a great educator. His name is John Belinsky. He's a PA. You may have seen him at a conference back several years ago. He's doing a little less teaching now, but he does this whole thing about who's your papa? And it's all corny, right? There's, pounding on the chest and all these things. And it sticks with you though, right? Because he said, and the mnemonic here is papa, PAPPA, right? Of the things you can't miss. So you can't miss a pneumo, which is over here. Pneumonia, you can't miss. You can't miss ACS. You can't miss pericarditis, and you definitely can't miss AAA, right? So tell me though, while we're on the topic, oh, good ones also, pleuritic, reflux, anxiety. These are great ones to add on. Tell me though, if you have a pericarditis patient, what would your clue be? Tell me any of the clues with their exam or how they're laying. Yes, Crystal, exactly. That patient won't lay flat to get the EKG, and you'll be like, sir, ma'am, please lay flat. And they just will keep popping back up. And Petra said, exactly, you'll have ST elevation in all of the leads. So pericarditis is a STEMI mimic, and it can bite you. In fact, we did have a case of a pericarditis that went to the cat because they were so convinced that it was a inferior wall MI, even though there was no reciprocal changes. So that's pro tip number 2 of the night, is that for STEMI, always to keep yourself safe, remember that you have to have 2 leads that are reciprocal with elevation and 2 leads that have depression. And that's the way you stay safe. Now, there's obviously caveats to that, right? When you talk about V2 and V3, it gets a little dicey, but in general, that's the overview of the 5 things you can't miss. So here are some red flags we thought we'd throw in for you. The patient that can't lie flat, you guys already got that one. That's a pericarditis. Substernal pain, especially pain that's worse with exertion or that's worse with emotion or stress or lifting, right? Those kind of things, those are concerning for ACS. One leg swollen. Tell me why I would be worried about that. One leg swollen. Yes, good. DVT leading to PE. Nice job, Petra and Crystal and Lashai. All you guys got it right. And Matt, of course. And then the pain that's localized, that's more consistent with like PE. So those are just some things that we need to think about with our exam. And if we hear them, can be a problem. And this is kind of going back to, you know, the probability of ischemia. We're always thinking about that. What's our pre-test probability? And I'm going to tell you that even though, right, that you can have sharp, fleeting, shifting positional pain over here, it doesn't always get you off the hook. It's still just low, not completely ruling it out. So even though we might have those patients that we think are musculoskeletal, it may not be. So just have a high index of suspicion all the time. That's the way to stay safe. So I'm going to toss the punt back over to Erin, and she's going to kind of go through a little bit on stress testing.
Thank you. So this is how a kind of a framework that I would encourage you to think about, who you should be deciding on pursuing a stress test, and then how you would also decide which stress test would be most appropriate for this patient, because that's one of the things I find a lot of clinicians will struggle with. And it's still something sometimes I'm like, which one is the best? In terms of, should I do an ECG stress? Should I do a stress echo? Should I do nuclear stress? Should I do a coronary CTA? Right. And we have multiple options. And, this definitely can vary depending on your work setting, what options you have at your disposal and your patient population. But these are a nice like structure and the way to think about how you choose a stress test. So the first would be, what is your clinical question? So not just is the chest pain ischemia, but let's dig a little deeper and ask, is there additional clinical questions? Are there additional differentials, right? Because it really comes down to what are your differentials here? So let's say it's just, exertional chest pain. That is maybe a younger patient. You may just want to rule out ischemia. But if it's somebody that's got dyspnea on exertion, that's going to change some of your differentials, right? And you may need to get a valvular, know what's going on with their valves and know what's going on with their EF. And you may want more information than just, are they getting ST segment changes when they're exerting themselves, right? And then the second question is there a baseline ECG that you have to make a decision off of? Is it normal? Particularly, do they have a left bundle branch? Because if they have a left bundle branch, we cannot use a stress ECG. It will not detect, or it's not going to be sensitive enough to actually detect ST segment changes. And so it's not going to be accurate. So we can't use a stress ECG in that setting. But I also find that, if let's say they've got Q waves on their ECG, my index of suspicion obviously jumps significantly higher that they've had an event potentially previously. And so again, I want to know what's their LV function looking like. Do they have wall motion abnormalities? How's their perfusion? So you want more information. And then the last one would be, are they capable of exercising, right? Because if they can't exercise, then we need to use, either a pharmacologic nuclear or a dobutamine stress echo, or maybe even a coronary CTA, depending on the clinical situation. So those are the kind of three questions that you want to kind of filter through in your mind to try to help guide like which stress tests would be appropriate. And then, Jen, can you advance the Ruben? And then from there, these are kind of how I break down the different primary stress evaluation modalities that we have to use. Jenny's asking about CT angio versus stress. I'll try to cover that. Let me go through this and I'll circle back to that. It's a good question. So ECG stress obviously is our cheapest option. Usually we don't have too much problem getting that covered by insurance. If they have enough, risk factors or strong enough like clinical situation where you have a high enough suspicion for ischemia. Obviously requires exercise, so they need to be able to exercise. But I also love that it shows their chronotropic and blood pressure response to exercise, because sometimes these patients, it's the issue is actually that their blood pressure is grossly uncontrolled. And when they get on and when they start exerting themselves, their blood pressure shoots up, right? And that's actually causing them some chest discomfort because of that blood pressure, and obviously putting them at risk. So that's a really helpful piece of the stress ECG. And then the next level would be a stress echocardiogram, which is going to then give you that structural and LV function assessment. So you can look at their valves, you can look at the aorta, you're going to get all of that structural component that you're not going to see on a stress ECG. And it's got a higher sensitivity. So it's got a higher sensitivity. You can actually see which, wall motion, which region is having wall motion abnormalities. And then you can use the dobutamine version if they can't exercise. And then the last major category is nuclear myocardial perfusion. I think nuclear, some cardiology practices really favor nuclear over stress echo, and that kind of depends on your setting, and also the tech. Like, you need to have an echo tech that's good at reading stress echoes, and you're performing stress echoes, I should say. They don't read them, but so sometimes that factors into it. But nuclear, you can have either exercise or pharmacologic version, and you're going to get both the perfusion. You're going to see their actual perfusion, and you can look for whether it is reversible versus a fixed perfusion defect, which actually tells you quite a bit about what's going on and whether the patient needs to be revascularized. And it also tell you a baseline general assessment of LV function. Although Jen and I, we always remind you guys in when we work in our mentorship group that, if the LV function is not normal on a nuclear, you need to confirm that with an echo. So we always double check with an echo, because sometimes the nuclears can be inaccurate. So that's a general overview of your stress modalities. And then the question, let me circle back real quick to Jenny's question about CT angio versus stress test. So she said, is it up to insurance? That is definitely a big piece of the puzzle, I'm not going to lie. So typically the way I go about getting to a CT angio is that they've had a positive exercise stress or nuclear or pharmacologic stress that then allows me to get coverage for coronary CTA. And I really use the coronary CTA as a way of potentially avoiding an angiogram. So if I'm not 100% certain that they need to be revascularized, if it's not like a slam dunk, this patient needs to be revascularized, then a coronary CTA can help to rule out obstructive coronary disease, right? Do they have an obstructive stenosis that needs to be revascularized? And then sometimes, if that's positive, and then they still need to go to have an angio, and that's fine, right? But it's an alternative, and there's definitely been newer, the ischemia trial, for example, really kind of showed the value of utilizing coronary CTA. The biggest issue, though, is that the insurance don't want to pay for it. So usually, you pretty much need to assume you have to have a positive stress test in order to potentially try to get that covered. So, is there any other questions before we move on to cases? Let's go to cases.
Here we go. So this case is something you may encounter. Of course, all the cases tonight are not real patients' faces, but think about this scenario. The patient comes in with a blood pressure of 180 over 100. She's a little tachycardic, and her pain radiates to her back. What's high on your differential? What is high on your differential? Yes, exactly. Good. Everybody said it in the Zoom feed here that we're worried about urgency and AAA. Awesome. Good job, you guys. So just having those differentials fresh so you don't miss them. For this patient, he says, my chest feels like an elephant is sitting on it. So what do we want to do for him? He's smiling, but he's minimizing. So we're concerned about STEMI. So we're going to get an EKG. Good. Exactly. Let's absolutely get an EKG on him. And then let's see what we can sort out on him, because the way we teach to look at 12 leads is we talk about doing a 10-step system with the first step being big sick or little sick. And what I mean by that is that, are we going to send this patient to the ED? based on this EKG right now? Are they having a STEMI or not? Can we stay and think about the EKG a little bit more? So do you see a STEMI on here? And again, you have to understand STEMI terminology, right? Reciprocal changes, contiguous leads, elevation. I'm just going to tell you that this patient was not a STEMI, but there was something pretty significant going on, and he did have cardiac arrest after this EKG was taken. So there was a clue there. Does anybody see the clue? And as KJ said, there's no STEMI. Good job. But what is the clue here? So there's exactly Erica, who is in our mentorship, perfectly spot on. And Argelia, you're also correct. And Lishai, if I'm saying your name correct, and Crystal as well. So yeah, good job. So here, let's just point it out for you guys. You have to understand that T waves should be not inverted, which is upside down, and they shouldn't be symmetric. And these T waves are not behaving. They are inverted and symmetric. So there's lots of different things that can cause this, but ACS is one of them. But potentially, yes, as Matt pointed out, thank you, I was just going to head there. Potentially the most worrisome thing on here is actually in lead V3. There is some biphasic quality here, which means that the lead goes up and down, or the T wave is up and down in the same lead. That's called biphasic, okay? And AVR is just chilling. There is a problem though. There is a problem. And good pickup on Crystal's part. The T waves in AVR and V1 are supposed to be inverted, and they're not. So that's also a clue. You also have some inversion over here, right? So there's lots of different problems, and this patient ended up going into cardiac arrest and needed a cabbage. So really, this is kind of, this is on the hit, I call it the hit list of things, right? Where you've got these inverted symmetrics. This is on the hit list of things that are a priority now. And biphasic T waves as well. They're basically signs of occlusion. They're signs of occlusion. And has anybody heard the term OMI before? Occlusion MI? So this would be signs that there's an occluded artery, but it's not a STEMI. And these things are just as worrisome. So if these are things that you're not comfortable with or familiar with, that'd be something to dig in on, because that's where the paradigm is shifting. It's shifting to these more subtle things. And honestly, I got to say that the left anterior descending really has the most ways to complain about things. And I call it the hot leads. There's the hot list of all the things now that they say we have to look for, but there's also the hot leads, and there's so many ways the LAD tells us if there's a problem. And remember, the LAD is basically fed or feeds V1 through V4. They're all contiguous, which means fed by the same artery. So let's talk about this gentleman. He is mowing the lawn, and his pain got worse. So how would you describe that pain? What would you say to describe it? You would call it a certain something. You would call it, okay, maybe, yeah, maybe angina, but there's pain on exertion, Morgan, exactly. So it's funny when I work with my interventional cardiologist, I always have to decide how to get them interested in a case, right? So when you're presenting, we talk about this as well in our mentorship, but when you're presenting, it's always important to sort of do the hook, right? You got to hook them before you tell them the thing. So if I ever bust out, hey, I've got someone with exertional chest pain, and then I throw in the history and then the EKG, they're hashtag sold. And that's like the hot button. And yes, you do have to sort of become a saleswoman, salesperson, right? So 160 over 100, not loving that. Heart rate 58, not loving that. But you know what? Honestly, he's probably not a beta blocker, so that could be it. But we also know that bradycardia could be from ACS. So I'm going to get an EKG on this gentleman, and you can see that there is something to worry about. There is something to worry about. Yes, BP is too high for sure, KJ. But let's make a decision about what's happening here. So yeah, Jim in Facebook says exertional. Exactly. So Crystal's on the ball. So is KJ with the chat here in Zoom. There is something going on. I'm going to point it out to anybody who doesn't see it, because we're going to go through it together. So what you've got here is oh, that line is a little thick, but you've got some elevation, as Crystal and KJ were pointing out, at least 1 millimeter and 3 in F on this patient. And the reciprocal changes over here in 1 and AVL. And by default, you have met your criteria for a STEMI. Now, yes, Matt points out also that you do have a right bundle branch block. That is partially important here. But also there's something, so are you going to send this patient to the cath lab? Yes or no? You've got 2 up, you've got 2 down. Yes, Crystal says yes. So does Erica. Erica says yep. Okay, in the meantime, while we're waiting for the cath lab, I do just want to wax poetic for a minute on something with you. The waxing poetic is that if you're ever wondering, okay, why at some point in a patient's AFib life, they need a stress test, this is why, okay? So this is the long lead pulled out for you here, just to orient you real quick. This is your 12 leads. This is 2 rhythm strips pulled out, but this one is the more important one. And you're looking for P waves. Don't have them. You have irregularly irregular. So this is none other than AFib. It's also a little bit fast. It's over 100. So it's going to be AFib with rapid ventricular response. But AFib can be an ischemic substrate, which means it's caused by a blocked artery, which is why at some point in their AFib life, they're going to get a stress test sooner than later to make sure that that's not why they have AFib. Because we'll talk about AFib in the mentorship, but in the nutshell, with it, you really need to ask the question, and with heart failure too, you need to ask the question, why? Why are they in AFib? Why do they have heart failure? And once you ask the why and you start getting the root cause, that's when the magic happens, right? It's not just about pulling out our prescription pad. We have to do some thinking about the whole thing. Speaking of thinking, this is where I think the thinking hat really has to come on, because if you have an older female patient who comes in and says, I'm tired, I'm going to say to you, I'm going to ask this patient, well, how is this different than your normal tired? Because every time I go through this whole situation with the patient, right? And I have to ask them, like, what's different? Because every female is tired. Give me one second. Do you want to take over really quick, Erin, on fatigued females? I'm going to let the dog out.
Yeah. So obviously we all, like we're all doing a billion things, right? So fatigue and tiredness is not uncommon, right? So asking them about is this different from your normal? And then what kind of questions would you maybe ask to hone in on that are more like cardiac, to look for cardiac causes of fatigue? What kind of things would you ask the patient? Can you put it in the chat? Check their meds, exactly. Dizziness, lightheadedness, exertional or not, good. High amount of stress in their life. I always like to ask about quality of sleep. Jen and I are both huge check for sleep apnea or peeps. So, that thyroid function, exactly, like the list goes on. But from the cardiac perspective, definitely looking for typical medications that could be causing fatigue. So beta blocker, Doreen, good job. Beta blocker is a big one, right? Are they on a beta blocker? If they are, do we need to potentially adjust the dosage or completely stop it altogether? Same thing if they're having lightheadedness, right? Are they hypotensive? Are they getting orthostatic hypotension? Try to do orthostatics in the clinic setting. And then, obviously if they're having exertional symptoms, that kind of changes our differentials, and we need to start looking for evidence of any type of ischemia. And then the other big one that is, you can see on this, AKG, is AFib, right? Anytime I have somebody who's just complaining of fatigue, lack of the pep in their step, right? Like if they're just like, I am just like dragging, I can't do my usual activity, I can't do my usual ADLs, that kind of stuff. Even if, they're not complaining necessarily of palpitations, they're not feeling anything like that, have a higher index of suspicion for AFib, for underlying AFib, especially in an older population, right? Who is at baseline, like higher risk for AFib. And then let's see, what else can you guys tell us about this AFib? Is there anything else, when we look at AFib, part of the puzzle is looking at if we're dealing with slow AFib versus what? Or not a slow, I should say, but normal rate. RVR. Thank you, Crystal. That's what I was looking for. And Matt. Yeah. So what would tell you that it's RVR? Jen mentioned it earlier, but what kind of a heart rate would we look for RVR? Over 100. Good, Crystal. Crystal's on fire.
Yeah, fast typer too.
I know, fast typer too. Great. Yeah. So heart rate over 100 would classify as AFib with RVR. Um, you know, what else? Let's see. Jen, was there anything else about this EKG
Yeah,
that you wanted to
I,
point
I
out?
just I just wanted to share one little fourth pro tip for the night, that when you have AFib, like if you're looking at a rhythm and you're not sure if you see a P wave, and you're sort of imagining you see a P wave, but you're not really sure, it's probably AFib. And then if you go on up to the PR interval up here and you see an asterisk, then that's also confirmation for you that, yeah, you're most likely dealing with AFib. So just little pearls to kind of think about that is helpful. So with her, we would want to do a whole deep dive on the labs you guys mentioned, loving all the labs, including that thyroid. And we'd have to make some decisions and have a discussion with her. So we kind of talk about the word tracks on how to have these discussions. We talk about how to choose the meds, both the antiarrhythmic drugs, rate control drugs, and the anticoagulants. We talk about that because there's a lot of considerations. There's a lot of ways that you need to protect yourself on your chart when you're prescribing these. And even if you're in primary care, this is a point I made earlier. If you watched my Instagram yesterday, I talked about the fact that I know a lot of you who are in primary care are treading water dealing with these patients and waiting for them to get into cardiology. And there's always this temptation to not anticoagulate somebody while they're waiting for cardiology. And that is where you can get into a lot of trouble. So you have to have some comfort level with it. You have to know the scores, the CHADS VASc 2. You have to know the Hasblad score. You have to know where to find them. So it's just, you can't wait, because if that patient strokes while they're waiting for their appointment, it's on you. And you didn't do due diligence, right? So didn't meet standard of care, even though it's not technically in your wheelhouse. Especially if you're working in the underserved community, you're going to wait a long time for them to get to cardiology. So you have to know AFib. You have to sort of know like the first steps of everything, which I think primary care is one of the hardest places to work personally because of that.
Yeah,
So
just to piggyback a little bit on
yeah.
that, I would just say, remember, what are you more worried about? This patient having a stroke or this patient potentially having a bleeding event, right? Because that's really, maybe in your discomfort with initiating an anticoagulant, that's really what it comes down to, is like, what's more risky for this person, the stroke or having a bleeding event? And there may be some where bleeding event is more risky, right? And that is the questions you kind of have to ask yourself.
So let's transition to this gentleman, a good case of somebody who had chest pain. Now I want to point your eye to something where the EKG says it's a normal ECG. Okay. I have to tell you that this is only correct maybe 6 to 42% of the time. And if you rely on this as your compass to see if something is wrong, you will be burned. And literally, you can see that. Well, first of all, if you know that the T waves should be inverted in AVR and V1. V1 is not inverted. That's problem number one. And all the rest of the T waves are supposed to be upright, and AVL is inverted. So with that, there's already two problems that are happening. And this gentleman has chest pain. Now, if you look at the time on this, this was this was an ambulance call. Actually, it was 10:39 in the morning. And whenever they talk in the new guidelines about getting serial EKGs, this is why. So actually, I didn't put it in here, but he literally, the next 4 minutes later, he literally had elevation in his V2, V3, and V4. And it now basically he declared himself as having a STEMI within just 4 minutes. So that's scary because it says normal ECG and you might be reassured. And so really don't feel shy about getting serial EKGs because they can help you. And one way you can do it is, I know we all work busy clinics and you don't have rooms, people are just, busting in and out. But if you have somebody who, let's say you're worried and they won't go to the hospital, this is the time where you could be like, listen, I'm going to put you over in this room. We're going to keep the monitor on you. I'm going to just recheck an EKG after, in 10 minutes from now. And you can trend it. It's kind of like we trend vital signs. Do the same thing with the EKG just to make sure they're not having something called dynamic changes, because that would be a game changer. Okay. There's also something to consider here. There's something forming in V1, and the something forming is actually a right bundle. And this, through the EKG case, this bundle actually completely forms, and people are always taught, oh, well, new left bundle is ACS, but honestly, right bundles can be too. And because of that, people don't get that piece, right? They don't know that. And either if it's an LAD, it can be a right or a left bundle. So just remember that it can be either. All right, so let's do the next case. This gentleman said he comes in for a checkup and he says, I had pain, but it's gone now. Am I okay? Patients always want to know, am I okay? Am I okay? So, well, you had some chest pain. Let's get an EKG. Let's see what we can find. And so the question here is he okay? He wants to go home. So what are we going to tell him? Crystal says, no, nope. Matt says not okay. Erica says not okay. Okay, but why? Why do we not think it's okay for him to go home? Because he's in this lecture? Because he's in this lecture? So technically, yes, Matt, yes. This patient shouldn't go home because they have the inverted symmetrics, right? Inverted symmetric, inverted symmetric, inverted symmetric. And there's actually something called, what Christopher and Matt are saying, there's something called Wellens warning, which is another thing that is on the hit list in that journal article. You guys can pull it up right now if you want to. It's called the Consensus Pathway Guidelines on managing chest pain in the emergency department, which is why you probably didn't hear about it. But are we still held to those same STEMI equivalents no matter where we work? Yes, we are. They changed the game on us, and a lot of us didn't even know, which is so disturbing. So yes, because you have inverted in V2 and V3, this is called Wellens warning. There's actually other flavors of Wellens warning. If you do not fix the Wellens within a week, they have a high risk of dying. So that is a big problem. So you're going to tell this patient, sir, and Wellens patients can be pain-free when you see them. They've had an episode of pain. It's pretty classic. So we need to get them to the hospital, and they will do urgent revascularization, urgent cath, basically. Probably will find something in his LAD. Okay, so how can I learn more about chest pain and hypertension and heart failure? And how can I interact with you guys more is the big question, because that's what we want to know. How can we interact with you more? So Erin and I have this cardiology fundamentals mentorship program, and it's starting on the 27th of this month. We're doing the official kickoff, get to know you call on the 20th, where we're going to just show you around, show you how everything works, find out what you want to learn and how to customize it to you. And Erin, I'm going to let you kind of walk through some of the features of the program for everybody who may be interested in learning more.
Yeah, absolutely. So Jen and I are very proud of this. It's like our little baby. And you are all part of our family when you become, when you work with us, and we let us help support you. So this is really designed for somebody who's predominantly working outpatient. All you could be working inpatient, outpatient, but we really focus on management from the outpatient perspective. So that's important to understand. But we're going to go over through a combination of pre-recorded lectures. So each week there's a lecture for the corresponding clinical topic. So you can watch that ahead of time or at your own time. And then on the live calls, every week we have one live call where we actually go through that clinical topic through the structure of case studies. So we're actually going to walk through applying this knowledge and talk through how we think through this process. And, from the perspective of experienced cardiology providers, plus all the other amazing mentees that are in the program, right? Because we're all learning from each other. And then the topics that we go through are the ones that are listed. We do chief complaints, heart failure, CAD, arrhythmias, AFib, EKGs, risk reduction, so prevention, lipid management, hypertension, and then valvular disease. So that's the core of the topics that we go through. And then the end of every call, we really leave as much time as we can to go through individual questions. So you guys can actually ask us the burning questions, the things that are coming up in clinic, bring your own cases that you can want to discuss. It's really meant to be a safe environment for you guys to feel like you can ask anything that's on your mind and there's no stupid questions. And we are completely just there for you, right? We're not associated in any way with your employer. This is a safe community. And then we do have 6 hours of CE credit that you can get as participating in the program. And then the other like piece besides our live calls and the portal with the recorded lectures is we have an amazing private Facebook group where you can actually post, questions, things that are coming up on the fly in clinics. And also you can post a case that you saw, and then Jen and I usually just kind of sprinkle in little nuggets of like learning knowledge and things to talk about and discuss in that group as well. So that's the structure of it. It's definitely, it's made for cardiology clinicians, but actually we've had quite a few primary care or urgent care NPs and PAs that have gone through that have done amazing, and they've also found it extremely valuable. So you don't have to be working in cardiology, I think, to get the benefit of it, although it's taught from the perspective of a cardiology clinician. So
I was pretty
yeah,
surprised that we had a lot of people that weren't in cardiology that really, really enjoyed it and benefited greatly and asked phenomenal
really good
questions. And
questions. Yeah.
yeah, so I mean, that was really kind of neat to see how everybody kind of came together and helped each other answer the questions too, as well. It wasn't just us.
Yeah, our calls are typically, Marie, our calls are usually on Wednesdays at 5 p.m. And Pacific time. Everything is recorded, so we usually post it in the Facebook group, the recording from the calls, and you can always, if you had a case that you wanted us to talk through, you could always post that ahead of time. And then everything goes into the learning portal, which you have access to lifetime. So the recorded lectures, all that you get access to for lifetime. So you're welcome. Yeah.
Yeah, good question. So we're super excited to kick this off. We don't have that many spots left. Actually, I think it's less than 15 now.
Yeah.
Some people joined today. But if you're interested in hopping in with us and learning more and getting some really like customized, personalized attention, one of my favorite parts of the calls is at the end when we just kind of open it up and we go round robin and people are like, okay, today I want to talk about XYZ. Can you please expand on that? Or they bring a case. That's the most fun part for us because we get to hear what's on your mind and just be completely responsive, which is really fun. So I like that. And sometimes what we'll do too is we've had members who have said, oh, I'm really struggling with this concept. So sometimes Aaron and I will just hop on and make a video in the group. Oh, Annie or whatever asked this question, and we thought you all could benefit from hearing it. So here's how I would say this to this patient, or here's how I would describe this Holter finding to the patient. Here's what I would do, and we give you the word tracks. We also don't we have some dot phrases or some
Yeah.
epic
We
dot
have
phrases available
Epic.
too?
We have also access to Epic template, or not just Epic, but smart phrases and templates, charting templates as well.
Yeah.
Um, so yeah, and then there's a wealth of information actually in the learning portal. Like you could spend quite a bit of time going through all that, but our aim is really to help to give you that foundational knowledge that then you can just build upon and you can feel so much more confident going in and seeing your cardiology patients and not having it be as stressful too, right? Because you feel like, hey, no, we've talked about this. I know what to do. So, which is amazing, right?
Oh, one other bonus, just FYI, because I know that a lot of you right now are thinking like, oh my gosh, Jen kind of scared me a little bit with some of those EKG findings and that list she's talking about. Like, I feel a little bit nervous about that. Well, the good thing is you also get that as a bonus. You get that 3-hour workshop I normally do all over the country. I get hired in to do this workshop. You get that as a bonus. So you can go like, let's say you purchase tonight, you can go to the EKG workshop in there and you can go to hour 2 of it and you can see exactly what findings we were talking about. I show you the list, I go through it with you and how to really knock it out. So when we talk about EKGs, really what we do in this group is we hone in on like the high yield, the no fluff, like let's get you super confident, super comfortable with the things that'll kill somebody that the machine is not picking up. Okay, we do some basics though too. We do some 12 lead and arrhythmias. In fact, we have an arrhythmia generator. So we'll put that up during half of one of our sessions and we'll say, okay, what's this one? What's this one? And we'll talk about why it is what it is. But it's really a fun, interactive, dynamic environment and just to completely designed to set you up to win. Yeah, so I think that's it for us. If you have any questions, let us know. Erin and I are both available in Messenger as well after this call, of course, to answer anything you're maybe too shy to ask now. If you are thinking about it, I will tell you that the spots are going to fill up very quickly. So you might want to jump on it tonight because once they're gone, they're gone. And
Yeah.
we try to keep it small.
We definitely cap it because it's really important that we have the ability to support everybody and everybody gets individual, support. So we do keep it as a small group. So, but does anybody have any questions that they want to ask on the call right now that you feel brave and empowered to ask with the group? Because I can stay on at least. I can stay on longer to answer questions, just general chest pain questions or questions about mentorship if you're interested. Feel free to either put it in the chat or you can they unmute themselves or are they automatically muted? You're welcome.
I think,
Petra.
I think they have to put in, I can unmute them if they want to come off mute. Just type in the chat if you want to add anything.
If you want
I
to
know a
ask
lot
a
of you are
question,
shy.
yeah.
Yeah, it's all good. I don't think anyone has questions, and that's okay. You'll think about questions later. And this is the website to go to grab your spot. There's a set of people that are coming from an institution that are signing up tonight that are going to take a significant amount of the spots. But if you're able to actually, when you go on and purchase, it means there's still spots left, so that's good. And again, we'll be sending this recording out tomorrow.
Yeah, you can also submit for reimbursement through your employer if you get CME funds. So definitely use that, right? Because this is a great unique way to learn cardiology because most of the times you can buy courses through some of the larger, institutional organizations that provide CMEs, but it's all just, recordings without any ability to ask questions. I think that's what we pride ourselves on is that this is a interactive learning rather than just watching a recording and watching a lecture. So the price is $349 for the program, $349. You're welcome, Lindsay.
Somebody asked the treatment for Wellens in the Q&A, and the treatment is putting a stent in and opening up that poor little LAD that's suffering. So yeah, thank you guys. Thanks for being here. We appreciate your time. Erin and I are here to support you. So just let us know how we can do that. And loving the interaction with you guys. And we'll send this out tomorrow in an email for you to review. And if you're in the 3-Day EKG Facebook group, it'll be there for you immediately. So that's the good news. I think most of you are. Anyway, Erin, any last thoughts? Otherwise, we'll wrap it up for the night.
No, thank you for being on, guys. We appreciate you being here and taking your time. I know everybody's busy, so.
For sure.
Yeah.
All right. Have a great evening. See you guys soon. Hope to see you in the mentorship.
Bye.
All right.